Today we have a great virtual spine journal club again going not just across North America, but around the world. I want to thank everybody for joining us, and it's a particular privilege and pleasure to introduce our great colleagues from the University of Maryland and their very well-known spine service. Dr. Steve Ludwig and his team have selected a topic that has become a literal daily discussion point, and that's posterior treatment of cervical spondylotic myelopathy and looking at a variety of variants. So I, first of all, thank them for their participation and also for this particular subject choice, which is near and dear to our heart. Good morning, Steve and team. I heard Dr. Gelb also, and many greetings from Seattle, and please take it from here.
Thanks, Jens, and we really appreciate the opportunity. You know, our whole department, on behalf of our ortho department and neurosurgery department as well, we want to thank the Seattle Foundation for allowing us to participate in the journal club today. The subject, as you alluded to, is common to every spine surgeon that practices worldwide, right? Myelopathy, cervical myelopathy is the most common cause of spinal cord dysfunction, right, worldwide. And clearly, as it presents to us in the clinic, the decision-making can often be sort of complex to a certain extent, right? Patients present with neck pain, arm pain, dexterity loss, gait abnormalities, end-stage visceral issues, and often in the face of multi-level cervical stenosis, when a patient's history, physical examination correlate with their plain and advanced imaging studies, and there's a subjective decline in their level of function. If patients are medically sound, we talk to them about surgical intervention because we believe it does affect their natural history of avoiding the potential decline in their neurologic function. And obviously, our secondary goals are to improve their level of function. As Jens already alluded to, it's often debatable in the face of a multi-level stenotic patient, whether or not with good cervical lordosis, the best treatments for patients are laminoplasty versus laminectomy and fusion versus even anterior-based procedure. So the purpose of this journal club is really to have the residents and fellows, they pick some key articles to discuss sort of where the evidence can sort of help drive us to our decision-making and guide our treatment. So let's just jump into it. Kaylin Fisher, one of our chief residents, is going to start us off with a couple of cases just to get everybody thinking about sort of decision-making in this patient population. So Kaylin, if you can sort of begin that would be great.
Good morning, everyone, and thank you for being here this morning. So as Dr. Ludwig discussed, we'll be discussing posterior surgical treatment for multi-level stenosis causing cervical myelopathy today. Our topic of discussion is laminoplasty versus laminectomy and fusion. Here's a quick picture of our spine department here at the University of Maryland. And here's a brief overview of our agenda today. We'll begin with 2 case presentations. And our goal of those presentations is just to get everybody considering what they would do for these 2 patients that we present as we go through the articles today. And then we'll finish up with a conclusion of what we ended up doing for those patients here at the University of Maryland. Our first case is a 47-year-old gentleman who presents to clinic with numbness and tingling in his bilateral upper extremities. Of note, he says he has no neck pain. His symptoms have been gradually worsening for the past several months. He says he has trouble with fine motor control, dropping objects, and maintaining his balance, denies any bowel or bladder issues. Past medical history is significant for hypertension and migraines. Of note, he does have a previous surgical history of a pharyngeal surgery, which was complicated by an esophageal stricture with dysphagia and motility issues in 2016. And he is also a newly employed truck driver, and he specifically mentions during the visit that he's concerned about his neck motion while he's driving. He's never been a smoker. He uses occasional alcohol socially and denies any drug use. On physical exam, he's in pretty good shape. He has a BMI of 25. He has no neck tenderness and normal cervical range of motion. He has grade 5 strength in bilateral upper and lower extremities. His sensation is intact to light touch in all dermatomes through the upper and lower extremities with a negative Hoffman's bilaterally. However, he does fail his tandem gait test in clinic. Here's a look at his x-rays here showing some spondylotic changes of his C-spine with disc space collapse at C5-6 most notably. And here's his cervical SBA here is just over 4 centimeters. Here's his MR image here showing 3-level cervical stenosis, centrally greater than foraminally. And here's his K-line here showing a positive K-line. So that's the beginning of our first presentation. With that, we'll move on to our second case. Our second case is a 62-year-old female who presents to clinic with 1 year of gradually worsening neck and left upper extremity pain, as well as tingling and numbness in her left 2nd through 4th digits. She also says she has occasional balance issues. She denies any dexterity, bowel, or bladder problems. She has a past medical history significant for morbid obesity and hypertension. She has never had any surgeries. She's a retired laundromat employee, never been a smoker, uses occasional social alcohol, denies any drug use. On physical exam, her BMI is significantly elevated at 45. She's tender over her cervical spine in the midline posteriorly and apprehensive to range of motion. Her motor is a grade 4 throughout her entire left upper extremity and a grade 5 in her right. She does note decreased sensation in her C6 to 8 dermatomes on the left. Otherwise, her sensation is intact. She has a negative Hoffman's, but she fails her tandem gait test in clinic. Here are her radiographs here, revealing some degenerative changes throughout her cervical spine. And here's her cervical SBA here at 16 millimeters. Here's her MR images here showing multi-level central as well as some foraminal stenosis on the left greater than right. And so as we go through the articles here, our hope is that everybody will just consider what they would be doing for these two patients, and then we'll come back with the conclusion of the cases at the end.
Okay, great. Thanks, Caitlin. So Josh, I think you're up. Josh Alexa is one of our neurosurgery chief residents. It's on our service as well. And Josh, you picked an article looking at posterior directed approaches for multi-level cervical stenosis, right?
Yes, sir.
Maybe you can begin that discussion. That'd be great.
Yeah.
I think these two cases just are very illustrative of the same problem, but two very distinct clinical presentations, right? Where hopefully maybe the literature can help guide us. Maybe it'll make it more cloudy what the best answer is for those two patients.
Yeah, so the first article we'll discuss here is an article published in 2017 in the Spine Journal under Dr. Failing's group that looked at a very simple retrospective study that looked at outcomes taken from the AO Spine North American International Perspective Studies, basically retrospectively looking at laminectomy versus fusion versus laminoplasty in that group. So, as I said, this is a retrospective review of prospectively collected data from those two data sets where they had specific inclusion-exclusion criteria to parse out these patients. Really, they wanted to look at adults that had degenerative cervical myelopathy with objective cord compression on imaging, and then whether or not they were treated with a posterior approach. So as we're talking about laminoplasty versus laminectomy and fusion, they were excluded if they'd had surgery in the past, if they had any active infection or cancer or other inflammatory conditions such as rheumatoid arthritis or ankylosing spondylitis, or some form of trauma or concomitant stenosis in another part of the spine, specifically lumbar. And then they ended up with about 266 patients in this cohort that they were looking at 100 of which were in the laminoplasty group and 166 in the laminectomy infusion group. And then they looked at 2-year validated outcome metrics that were already included, specifically NDI, NURIC, MJOA, and SF36 version 2. So to review the results, so their baseline results were well matched between the two groups, other than a couple things, notably that the authors were astute to note. The MJOA scores were actually significantly different between the two groups at baseline, with the laminoplasty group actually more severe MJOA group than the laminectomy infusion group. And one thing they did not circle here, which also is a little bit more important for the discussion as well, is the regions in which they had the surgery. Specifically, the laminoplasty group were significantly operated in the Asia Pacific area, and laminectomy infusion were a little more diffuse. Going forward, looking at, and then of course they just took the 2-year outcomes and looked at it by surgical approach. To start, they noted that initially they saw an actual specific difference between the laminoplasty and laminectomy infusion group. Both groups had significantly improved outcomes at 2 years. But the before an adjusted analysis, they noted for some reason that the laminoplasty patients may have actually had a higher increase change in their MJOA scores at 2 years, and a trend toward a significant change in the NURIC score as well. However, because that was somewhat confusing and didn't quite make biomechanical or neurologic sense, they adjusted for the already changed MJOA scores between the two groups, and actually saw that this difference actually did not hold through when they adjusted for the differences in baseline MJOA score between the two groups. So saw that there really was no significant difference when they adjusted for that. The one thing that they did note as a difference is, and they looked at specifically other hospital metrics like hospital stay length and also duration that they stayed in the intensive care unit. And they saw that in the laminoplasty group, there was a significantly longer stay in the hospital compared to the laminectomy infusion group overall, as well as an increase in the ICU duration, even though that amount of time in the day is almost still about half a day. So some key takeaways from this paper, basically the conclusion that the authors came to after the review of this literature and in their discussion was that first, both surgical techniques really do offer an effective way of improving disease severity and functional status and quality of life across these patients based on all these validated outcome metrics that they looked at in 2 years. However, they also did note that laminectomy infusion on average, which I did not mention earlier, but had a longer operation. However, the laminoplasty were shown to have longer hospital stays overall. And they mark on this in the discussion, basically saying that it's likely due to potentially cultural differences between the two groups, because again, noting that the laminoplasty group was primarily in the Asia Pacific groups, where the authors commented, felt that this is likely due to the fact that they stay in the hospital longer and on average for most surgical conditions in that area of the basically the geographic differences are what really probably led to that. However, it's hard to say. But it's essentially otherwise the actual surgical technique for improving outcome measures was essentially equivalent between the two. Strengths of this talk is that they had a very high follow-up rate, which is again because they used data from multi-center prospective studies, and as well as they offered an adjusted analysis for the baseline characteristics from the MJOA scores. Limitations of this, of course, it was not a randomized control trial, however, and it's really a retrospective review of prospectively collected data. But overall, I think it offers a good review of these patients and shows that they both can be effective ways of treating cervical myelopathy.
Yeah, thanks, Josh. Anybody have any questions for Josh? A couple of thoughts, just immediately, Josh, and you really pointed it out. And this article, I think, in my mind, is an incredible, lift of work. And you brought it out, already. There's just a huge bias, right, in terms of, because it's not prospective, it's not randomized, right? There are other studies that look at that, right? But you pointed out some of the keys to the study. It really doesn't tell us in the properly selected patient, who's the best candidate for a laminectomy infusion, who's the best candidate for a laminoplasty. It just tells us that neurologically people will get better regardless, right, of which technique they choose, but it doesn't really optimize, right? It's really confusing to me and confounding. I guess there is a bias obviously as well in our Asia Pacific cohorts and colleagues, that treat these patients. They clearly, most of our experience at Maryland, and maybe Jens in Seattle and Jack, Texas, can comment. I mean, we put almost all of our patients on a floor unless there's some other inherent really major issue. We're not sending any of these patients to the ICU. Our length of stay for laminoplasty and laminectomy infusions are pretty much the same, so it's sort of surprising to me that laminoplasty patients sort of stayed longer, right? I think there's just some cultural issues that I think you brought that up maybe, and there's some kind of bias from that. And all of the laminoplasty patients most of them were from, Europe, Asia Pacific, right? Where the procedure was the birth of the procedure, right? And that sort of makes sense, right? North America, we're very biased, as you alluded to, towards laminectomy infusion. Even at our institution, we are. I don't know if Jens in Seattle, if that's your experience, or Jack in Texas, if those are your experiences as well.
Yeah, Steve, you raise a very good point. So I love doing laminoplasties and selected patients. It's always a holiday for me. And Rod and I were just, again, commenting on what you pointed out so astutely, which is if we kind of look at data from research projects, we should transfer their key kind of parameters like length of stay to our own experiences. And this is just several standard deviations away from what we do. I'm not bragging, but I think in the US, a 1 to 2 day hospital stay in non-complicated patients for any posterior multilevel procedure is pretty much the norm. And that's not bragging, that's realistic. And right there's something that's really off. So I'll just shut up here. Rod?
Yeah, no, I agree.
Is your microphone on? Yeah.
Yeah, I agree with Jens. I mean, and I think Steve, you pointed out, we don't put people in ICU, and rarely do we have these patients stay more than 2 days. So.
Yeah, I would agree. I think it does reflect a cultural change. On one of my visits to China a few years ago, they asked me if I was aware that the white blood count after an ACDF typically spikes on day 11. I said, how do you guys know that? He said, well, we do blood tests every day. And I said, you bring them back home? He goes, no, they stay in the hospital for 3 weeks. So, it's a very different expectation among the patient base from region to region. And it's really hard to mix them. But, that's where statistical analysis comes in handy, when you can point out that there are big differences in your baseline demographic assumptions.
Yep, agree. So any other thoughts? Dan, Gail, anything with regards to this? Okay. All right, why don't we move on? I think, Bach, I think you're gonna talk about the meta-analysis to try and sort of clear the muddy water of who's the best candidate. Maybe this review article can help sort of guide our treatment. Bach?
Yes, thanks. Absolutely, it's a big article. They reviewed lots of data. So it's been published in Journal of Neurospine. It's very recent in 2021. Getting down to the bare bones, does laminoplasty or laminectomy with fusion provides better outcomes for patients with cervical myelopathy? So it's a review article. In summary, they included 38 studies, and 18 studies showed statistically significant differences in clinical outcomes and costs. It included 10 prospective and 8 meta-analyses. So what is nice about this article, that results were reported by classifying them into prospective studies, retrospective studies, and meta-analyses. And in conclusion, article concluded that both laminoplasty and fusion each provide satisfactory clinical outcomes. However, laminoplasty may result in better cervical range of motion and less cost, less length of stay and operation time, less paraspinal muscle atrophy, and less rate of paresis as compared with fusion. How to go back? Go back. So this is a summary of meta-analysis, overall 6 articles. I'm going to go only on this first column, which shows the significant differences detected in fusion and laminoplasty group. And it says that mostly in the laminoplasty group, they have a lesser rate or C5 palsy, lesser rate of overall complication, lesser cost, and overall longer OR time with fusion. The next slide is about the primary articles. Again, a list of the primary articles showing significant differences in 2 groups. And again, here we have with laminoplasty, greater improvement in MGOA score, and with fusion, a lower range of motion, and more bleeding, longer hospitalization, and more nerve palsy with fusion. One interesting study which is pointed out in this article, which is really, and we talked about that, Dr. Ludwig mentioned about that, and I believe this worth discussing a bit more. A study conducted in 2012, which is pretty small in number of patients. However, it has a unique aspect which other studies didn't bother to explore. That's the preference of the surgeons. It found out that majority of North American spine surgeons prefer laminectomy and fusion over the laminoplasty. And authors pointed to potential influence that the strong preference of fusion might have a legacy on future generation of spine surgeons. So this is a really interesting point. 70% of North American surgeons, they prefer laminectomy and fusion versus European and Asian surgeons who does not exhibit such kind of bias. A discussion point in this article is the cost. First the cost, and here they show clearly that the median cost which was included in all surgical instrumentation and hospitalization fees were greater in fusion group than in laminoplasty groups, and it's almost $20,000 more. Preference for laminectomy with fusion. The question is, why do North American surgeons prefer laminectomy fusion? Is that because it's indications for laminoplasty are really specific? You have to have like specific type of patient to perform laminoplasty, and is it because there are many different techniques to perform laminoplasty versus only one simple technique to perform laminectomy in fusion? Indications and contraindications. So I mentioned already, and we talked about that. Dr. Ludwig mentioned earlier. Indications for laminoplasty are quite specific, and also article discuss future directions, and they mentioned about DTI, diffusion tensor imaging, which is associated with better predictive values to predict the outcomes of surgical management as well as cervical myelopathy. So that's it for my study. For my article.
So does this article, I mean, I know it's a review article, but does it muddy the water even more, or does it make it even clearer? So there's 2 patients that Kaylin had sort of brought up, right? I mean, clearly these meta-analyses and the analysis from looking at all these articles, it's important to look at, right? It gives you an amalgamated look at where the literature is, but does it really truly direct what's the best, right? Neurologically, right, we're showing equivalence, right? Laminoplasty, there's some benefits with regards to neck discomfort, range of motion, reduced stay, potentially complications, right? How you look at costs, right? It's very complex, right? Are you looking at charges? Are you looking at costs? Are you looking at actual reimbursements to the facility, right? Those are very complex. You know, why do North Americans love the laminectomy and fusion, and why do the Asian group of surgeons, right, love laminoplasty, right? Does it really delineate the granularity, right? I guess, Dan, Gail, what are your thoughts? How do you choose between the two?
Well, can you mute? I will tell you that I don't do any laminoplasty because I don't do enough of them to make myself good at it. And my question to the group actually is just that. Why? I mean, alignment, you got to do a you can do a laminoplasty or not. If you're kyphotic, you can't do it. If you have instability, you're probably going to want to fuse. But why aren't we doing laminoplasty in everyone else? I mean, if people are very spondylotic, is it worth doing a laminoplasty? Or should we go on and just do a fusion?
So what drives Jack or Jens or Rob? What drives you to choosing laminoplasty? If all else is equal, their sagittal plane is good, their K-line's positive, right? I think they have a mild to moderate amount of neck discomfort or pain. Is there anything in particular that drives you towards a laminectomy and fusion versus laminoplasty?
It's a really good question. And in our motion preservation courses chaired by Jack Ziegler and Scott Blumenthal, we've addressed this now every year. One thing that I hope doesn't drive it, but I can't totally rule it out, is the reimbursement. There's clearly a way higher reimbursement for surgeons with a multi-level posterior fusion as opposed to laminoplasty. As Dan said, I love the surgery, but it's something that's honestly a more fickle surgery. You have to be very diligent at it. And then results heterogeneity. What I've seen in surgeons who've tried to do it and, quote, failed is that I think that they have a very weird technique. They kind of skip some levels here or there. There's a lot of improvisation there, which I think can mar your results adversely, because if you don't have a stable posterior column, it'll tend to create more problems and floating grafts and reclosure. So I think those three things are serious factors, because I use it in high functioning individuals. There are surgeons, there are military people, and it's been a fantastic procedure. Where I interestingly don't use it is what it was initially described for, which is OPLL, because I have a strong suspicion that the OPLL keeps growing. I'll punt to my left here. Rod, why don't you do laminoplasties? I'll put it right out at you.
Honestly, I've seen a lot of the patients that Jens has operated on, and they do quite well. And I don't know, they definitely have less neck pain. I'm not sure how I can explain that, because you're still taking down the posterior muscles, the tension band, I just haven't really done a lot, but I think it's a great operation, and patients do extremely well. I think the main thing for me is, and I think Dan pointed out, is knowing when to do the laminoplasty. I think choosing the right patient to do it on. I think OPLL would be, for example, a patient that I would not want to do a laminoplasty on.
And Jens, I would add also that it's a fun operation. It's technically challenging. It's a good teaching operation because everything is open. It teaches good skills. So it's an operation that we enjoy doing in a teaching center, but you have to pick your spots. And as Dan said, instability or kyphosis, we'll take that out of the decision tree.
Yeah, I think it's a conundrum. I think what drives me, the neck pain, right? In the properly, I think, once again, it's all about selection, right? And I think everybody brought that out. In the properly selected patient, right? If you can find somebody that has congenital stenosis, not a lot of neck discomfort or pain, that's not the driving, symptoms with neurologic issues that are consistent with myelopathy, that is highly functioning. I think Jens or Jack sort of brought that up. I mean, that is a patient that is perhaps, with all the cervical parameters that are in line, is a patient for a laminoplasty procedure. At least in our practice on the East Coast, we just don't see a lot of those patients. It's just not common. I mean, most of the patients we see are end-stage spondylotic, myeloradiculopathy, bilateral, a lot of neck discomfort and pain. right, that need a fusion for that relief of a large component of their axial neck pain, right, that is helpful. So I don't know, it may be, it's just an operation at some point looking for an indication, but you have to select the appropriate, person. So I don't know, I think that sort of leads into our next article that Manif brought up, does laminoplasty lead to worsening axial neck pain? I think this can sort of clear the waters a little bit in choosing the right person, right? This article, I think Manif, is hopefully you're going to bring out is all about selecting the right person with respect to their neck pain. So Manif,
Yes,
can you
correct.
go over that?
Can you please put up the slides at university? All right.
You see them there, Manif?
Yes. All right. So the article is titled Laminoplasty does not lead to worsening axial neck pain in the properly selected patients with cervical myelopathy. A comparison with laminectomy and fusion. This is a retrospective study that was conducted in Vanderbilt and Emory universities between 2007 and 2015, and it was published in 2017 in Spine Journal. It was conducted to determine whether laminoplasty was associated with worsening axial pain in a properly selected patients of cervical myelopathy by comparing pain and other clinical outcomes to a cohort undergoing laminectomy and fusion. One impediment to wider acceptance of laminoplasty, as we have discussed, is the concern that it exacerbates or creates axial neck pain, and the previous literature failed to resolve this issue. So in total, this study had 85 patients included in the laminoplasty group and 52 patients included in the laminectomy and fusion group. The patients were selected for cervical laminoplasty if they had met two criteria. The first is that axial neck pain was not the dominant complaint. And the second is that it has the alignment of neutral to lordotic sagittal angle between 2 and 7, C2 and 7. Those with predominant complaint of axial neck pain or were kyphotic at between C2 and 7 had laminectomy and fusion. As you can see, there was no significant difference in age, sex, body mass index, follow-up duration, modified Japanese Orthopedic Association score, or short form 30 SF36 mental component score. The average clinical follow-up was around 18 months and radiologic at least 1 year. There was significant difference in the preoperative neck disability score index, short form SF36 physical component, and the VAS neck and the VAS total was worse preoperative values in the laminectomy and fusion group, and that is expected because that was the inclusion criteria, that those with neck pain underwent laminectomy and fusion, like predominantly neck pain. In terms of radiologic parameters, there was no significant difference in Miyazaki spondylosis score, T1 slope, 2 to 7 SVA, forward pitch, or AP spinal cord dimension. There was also a significant difference in the preoperative lordosis. That's also from the inclusion criteria. Next slide, please. Laminoplasty showed that it was associated with shorter operative time, less estimated blood loss, shorter hospital stay, with no difference in the rate of perioperative complications such as infection or deltoid weakness. Next slide, please. The VAS of the neck significantly improved at 1 year in the laminectomy and fusion group. As you can see, visual analog score of the neck was slightly less at 1 year with laminoplasty group, but it did not reach significant statistical significance. Therefore, axial pain scores, VAS neck did not significantly worsen following laminoplasty. In fact, it improved, but it was not significant. However, the overall VAS total improved significantly in patients undergoing both laminoplasty and laminectomy and fusion groups. As you can see in these figures, the neck disability index, if you look at it, which is an instrument that shows how neck pain and results in dysfunction and affects quality of life of patients, had significantly improved in the laminoplasty group from baseline to 1 year. It also improved in laminectomy and fusion group, but not in a significant manner. With respect to neurologic recovery, which is measured by the Modified Japanese Orthopedic Association score, it significantly improved in both groups at 12 months of follow-up. In contrast, you can look at the short form 36, the physical and mental components. Which are like perhaps less specific to patients undergoing cervical spine surgery, did not improve in either, did not significantly improve in either groups. Next slide, please. In regard of radiologic parameters, there was a small amount of lost lordosis in both groups, which was statistically significant in patients undergoing laminoplasty. Next slide, please. In conclusion, in a carefully selected group of myelopathic patients without significant axial neck pain or preoperatively and appropriate sagittal alignment, laminoplasty did not lead to worsening axial neck pain, and it was associated with significant improvement in the clinical and myelopathic outcomes. This finding likely applies only, as I said, to appropriately selected patients and not necessarily to be generalized to all myelopathic patients. Thank you very much.
Yeah, Manaf, great job. I think that was a great review. You know, this is a really nice article you chose, right, where I think the data and the results support the conclusions, right? But it's a little still cloudy to me, right? The properly selected patient, right? Axial neck pain, is it diffuse, right? Is there any, you know, when you get into the granularity of this, was there anything that they said about the selection, right? As we talked about, it's all about the right person.
Yeah, exactly. Like they produce this bias, but I think I understand that. Like ideally, there should not be a selection bias, and the baseline characteristics of both groups should be equivalent and comparable to have a good study. In this group, they created this by having this selection criteria. Actually, I look at this study as more less than a comparative study. This is not a fair comparison. So I look at it more as still a non-comparative study, just putting together these two groups, these two cohorts, and looking at their results, because it's not fair because of this very strong selection bias. And it's not generalizable by any ways. If we want to have a fair comparison, we have to have we should just include patients with a certain selection criteria that is with lordotic and that are lordotic and that do not have mechanical axial neck pain, and then randomize them into those two groups which are laminoplasty or versus laminectomy and fusion.
Yeah, for any of the attendings on with everybody has a profound amount of experience that's on the call or on the Zoom meeting. Any way you can help for the participants delineate, do you use a VAS score as your cutoff for laminoplasty versus laminectomy and fusion? Do you find that it's just irrelevant, you can't predict, and it's not useful? Do you use injections? How do people discern, right? Because at least in my experience, everybody has neck pain. It typically seems diffuse. It's typically associated with bilateral upper extremity radicular symptoms associated with their spastic paraparesis. So at least in our patient population or mine, and I'm not quite sure I can generalize to other practices, I think it's just hard for me. And that's why I am so inherently biased towards a laminectomy and fusion. I'll perform 20 for every one, right? I don't know. Does anybody have any guidance? I see Charlie's on, Sansur. Any thoughts about that, Charlie?
I sometimes realize, sort of like in retrospect, when I do a laminoplasty and, I warn a patient about the fact that he may have some potential worsening neck pain, but some of these patients are really driven towards motion preservation, and they still want a procedure that will preserve motion, and they're willing to take the risk at having some residual neck pain. And so sometimes a happy medium can be achieved where you do a multi-level laminoplasty and you preserve motion at those segments and provide more space for the spinal cord. And there may be like a lingering level of like 1 or 2 levels where things are really symptomatic in terms of maybe foraminal stenosis that may be present or some other process. And then after the laminoplasty is done and they've had enough of a chance to recover, I may choose to do like a 1-level ACDF, and then that way they get the benefit of the laminoplasty and the stability from a fusion in an area where there are residual problems. And sometimes in those patients where I do the laminoplasty and I warn them about neck pain, sometimes I see them in clinic and their neck pain has actually gotten better, and some of the neck pain may be due to the innate C3-4 distribution where there's C3-4 stenosis, and you open up the C3-4 lamina, and that's part of this, the C3 and C4 dermatome, is the neck. So I've seen that happen too, but it's hard to predict because neck pain is so multifactorial.
As far as post-op neck pain, laminoplasty had a bad rap at the beginning because when we first started doing laminoplasties, we were using no internal fixation. It was really the Japanese techniques of bone struts or sutures. And I found that once we started adapting to instrumentation, post-op neck pain became much less of an issue. The other part, Steve, as you were saying, is pre-op. How do you evaluate a patient preoperatively? And we just subjectively say that if they have a significant amount of neck pain or more neck pain than myelopathic or radicular pain, then they probably ought to get a fusion to take care of it. But I don't know any metrics that tell you exactly where the cutoff is.
Let me just add to that. This is a great point, and this is a super article. Thank you so much. Howard Ahn gives a great talk about the lack of our understanding and differentiation of neck pain. And there's neck pain, and we all know that neurologic compromise, central and foraminal stenosis, for instance, is a contributor to neck pain, and that there are shoulder-related neck pains, there are various root-related neck pains, etc., and there are myofascial neck pains. We're not taught and we're not capable of differentiating all those sufficiently. And the Japanese literature, which led to the negative association of neck pain with laminoplasties, I've always struggled with the high heterogeneity of how they fix their laminoplasties. And some use sutures and some do this and that. And we assume that all surgeries are the same, but that's clearly not the case. And again, when I see failed laminoplasties, there's usually really bad technique there with non-stable fixation. So I think we don't differentiate neck pain well enough, and B, surgical technique does play a significant role. And I want to shout out to Ken Yanamura, great point, how we preserve, if possible, the rotator tendons at C2, and if possible, C7 or T1 especially, can make a big difference right there also. So having a certain degree of surgical savvy and understanding helps. So thank you.
Yeah, I think those are all phenomenal points and really helpful, in terms of the understanding and the evolution of, laminoplasty as a technique. The only other thing in the laminoplasty patients that I've done, we really, and my mentors have taught me this, is to really encourage early active, range of motion, because especially I think to Jack and to Jens's point, right, with modern day fixation, before we used to use suture anchors, right? We used to sort of MacGyver things together and carpenter the bone, it made it really fun, but it really made it awkward to manage those patients, and we're ambivalent about getting them to move. But with the modern day fixation, it's really modernized and it really has enhanced our ability to get people moving. So I think those are really fabulous points, in terms of getting people better outcomes and reducing their neck discomfort and pain. So go ahead.
Steve, just to reiterate what you said, as Jack said, when we first started doing this, we used to keep them in collars, Philadelphia collars for 6 weeks or so, and they were miserable. They were stiff. But now that we have the little plates and fixation, we basically put them in a soft collar, let them move right away, avoiding the extreme ranges. And I think that made a big difference in terms of neck pain. So although I don't do a lot anymore, when we were using the fixation, and my younger partners do, they really seem to have a lot less neck pain if you get them mobilized early.
Yeah, Rick, those are important points. I guess real quick, because we want to move on to just any discussion of myelopathy has not been had unless you talk about anterior, right? So I think Jack is going to talk about an article, if we can bring that up. But real quick, from the attendings that are on, I don't use any cervical collars for fusions, for laminoplasties post-op, just for comfort, maybe a soft collar. I don't immobilize the patients. That's the point of our fixation. Does anybody put their cervical laminectomy fusions in a collar? Just a quick sort of go around, yes, no, or laminoplasties in a collar?
I don't put anyone in a collar. I don't know about Jens.
I just use a soft collar for comfort time. They can use it for a couple of days just until their wound feels better.
Yep.
I still use a collar for my laminate fusions, but I do it mostly.
The collar for you, Charlie?
Mostly for me, but also when patients have like poor bone quality,
That's a good point.
Yeah,
that's a good point. That's a really good point.
And the only thing I do, I just counsel them. I say just avoid the extreme ranges of motion, but normal range of motion I'm okay with.
Good point. So Jack, if you can do a quick synopsis in about 5 minutes of this article, that'd be awesome. So we can bring home the, show everybody what we did on those cases.
Yes, sir. Thank you very much. So I'm going to be talking about this study that was in JAMA earlier this year. It's a multi-center randomized controlled trial. They were looking at whether ventral versus dorsal surgeries for myelopathic patients provided better improvements in their SF36 scores as their primary outcome measure. I think that they actually selected a very good representation of patients that often would lead us to have to just choose between the two. And these are patients that have up to mild kyphosis, but certainly nothing over 5 degrees, no OPLL and no revision cases, and overall reasonably healthy patients. They were 45 to 80 years old, and the surgeries that were performed were either anterior or posterior, and then between the anterior and posterior is at surgeon's discretion to do a laminectomy infusion or laminoplasty. And then for the ventral surgeries, most of them were ACDF, but they were also allowed to do a single level or corpectomy as an inclusion criteria. The primary outcome was just looking at change in outcomes at 1 year, and then secondary outcomes, they looked at complications, work status, cost, and some other outcome measures. The demographics, as I mentioned, these were patients where they followed them up to 2 years. They did a power analysis that came up just for the SF36. They needed about 160 patients, which they did get. There's fortunately very little crossover, just one patient in one group and then 4 patients in the dorsal group that did cross over to the other. Their baseline scores were moderate myelopathic patients, so nothing, for the most part, not very severe. And if you look at their number of stenotic levels, these are also pretty representative of what I think we usually see, which is anywhere from 2 to 4 levels, but most of them were 2 to 3. Not too many patients were 4 levels. So for the primary outcome measure, they both improved to a clinically significant amount, over 5 points on the SF36. At 1 year, they improved, and then they held that improvement for 2 years. So I think that's very reassuring that regardless of how you treat these patients, they do seem to improve their functional status. If you look at the difference between laminoplasty and the laminectomy infusion, there was actually improved results for laminoplasty over the fusion, although they didn't have good subgroup analysis for these patients because they didn't power the study to compare these two groups. And so they are thinking that there's probably an underlying bias because it was at surgeon's discretion. And I think what we've talked about at length already in this is that there's certainly a much finer selection that we use to pick a laminoplasty patient based off of how young they are, their functional status, and how we want to preserve that. So almost certainly that has led to these results, and they did not claim this to be something that you can hang your hat on versus the anterior versus posterior. But it's certainly, as you can see, both patients improved here, and there was just a slight change between 1 and 2 years. However, at 1 year, there was no significant difference between the two, and then at 2 years, there was a slightly increased benefit for the posterior patients versus the ventral patients, although 6 points versus 5 points, it's hard to say that is a significant difference between the two. Secondary outcomes, there was no change in any of the secondary outcome measures, no significant differences, with the exception of complications. But the caveat to this is that they included dysphagia as a complication. Anything over 3 months was considered a major complication. Now, almost all of these patients had a more transient, short-term dysphagia, and that pretty much accounted for all of the minor complications that they included. So if you remove dysphagia from the equation, the results start to look much more similar. When there were more infections in the posterior group, but we're talking one person had a wound complication and one person had a surgical site infection. So that's still like 4%, and one patient out of 60 is still pretty reasonable. Their 30-day admissions were also a little higher. That's mainly because of their infections, and their C5 palsies were also just slightly higher. But overall, the results were very similar, but just with the caveat that they were not powered to detect differences in the secondary outcomes. So a lot of this is probably more just statistical variations than it is true differences. So that for the discussion, overall, the conclusion is that there was no difference between these two approaches for this patient population, which is mild to moderate myelopathic patients with minimal kyphosis, with anywhere from 2 to 4 levels. Dysphagia was the primary complication for the ventral surgeries. The main weaknesses I discussed really are just because laminoplasty was not uniformly performed. Only 1/3 of the studies did it, and there was almost certainly a selection bias for these patients that probably led to the greater improvements in their scores compared to the fusion patients. But I think this was a very good study. It's hard to argue with a multi-center randomized trial, and you can conclude that I think whatever a surgeon is doing, you can take comfort in the fact that short of having significant kyphosis, both approaches to treating cervical myelopathy are effective and have durable outcomes out to at least 2 years.
Yeah, Jack, great job. Great discussion. I think as we talked about, no discussion of myelopathy has really been had without a, discussion of the anterior-based procedures. I guess, the interesting thing about this article, right, the complication rate after anterior-based surgery is so much higher, right, compared to posterior-based surgery. And that's because of the dysphagia issues. And I guess the question is, is dysphagia really a complication, right? I mean, or is it just a side effect, right? We operate on somebody's spine posteriorly, right? We put an incision in the back, and then is back pain a complication of a posterior lumbar based procedure, right? If we do a lateral based procedure, we go through the psoas and it hurts, along their hip and their lateral thigh for a period of time. Is that a complication? It's just a side effect, right? If we operate on somebody's femur, right, and we fix their femur, right, and we go through their muscle, their quad or whatever, right, and their quad hurts, is that a complication or just a side effect, right? At some point, prolonged dysphagia requiring a feeding tube, right, that's a complication in my mind, right? But I don't know, if you took that out of the equation, when all else fails, once again, it's sort of, the numbers look pretty similar, right? And it's really what's going to be what you can make best work in your hands. I don't know if anybody has any other thoughts about this article or anterior versus posterior, before we bring it home with the discussion of what we did. Maybe we can bring up those slides as anybody has any comments.
My main comment is Steve and Dan and Charlie, all active at CSRS. I think we should really try to reinvigorate formal training and have a consensus as to how do we do a laminoplasty best. This would be a great opportunity for a multidisciplinary focused society like CSRS to kind of really re-explore the popularity and how it's best done.
So to find the indication for laminoplasty, that's what you're saying, Jens.
Indication and technique.
There you go. Yeah. And that's part of the conundrum, right? As you bring up, right? There is so many different techniques with laminoplasty, implants, right? The implants are very, are somewhat different, whether or not you're going to stick a bone graft in or not, whether or not you're going to skip a level, whether or not you're going to do a French door, T-saw, open, all those play a role. And that's probably part of the conundrum in the bias towards laminectomy and fusion, because I think it's a much less fiddly, as I think you brought up or somebody else brought up, in terms of technique. So Kaylin, let's bring up the two cases and bring this home. Case one, right? That was the case, Kaylin, that you presented our recollection. This was a young person, no neck pain, worker B, congenital stenosis, right? I think.
Yes, sir. This is our 47-year-old male truck driver concerned about his neck mobility.
So I think, I don't know if anybody has any thoughts or if this is crazy or if this was improperly selected. Charlie, is this somebody that you would offer, a laminoplasty? That's what we obviously did, right? We're showing you what we did. I don't know, any thoughts about this? A younger person, 47, truck driver, needs his range of motion back, not really significant amount of neck discomfort, based upon his VAS when he came in.
Yeah, I mean, I guess without seeing the MRI, seeing now that I see these films, I presume that he had multi-level stenosis. Given his desire for motion preservation, I think this was very reasonable, and at the end of the day, he might need an ACDF at that one level, but at least the rest of his levels have been preserved.
Any thoughts or comments from the panelists before we move on to the next case?
Stephen, do you do undercutting under C2 and the cephalad part of C7 so that you don't get a kink? Because you did a really nice job of canal expansion in the middle. But that was part of my learning curve, I know, is to do an undercutting dome at C2 and the same thing at C7 so that you expand that without taking down the lamina.
Yeah, I think those are really good points, important points. I usually take a diamond burr and sort of diamond out and take a kerosene and undercut both those levels, Jack. Yeah, I think that is definitely part of the protocol. Actually, one of my mentors, John Heller, taught me when I was down at Emory during my fellowship. But those are important pearls to the proper technique. I think the only other aspect of this, some people will do skipped points of instrumentation. Some people will do every level, right? Those are other issues. Some people will put bone grafting in between, that adds cost, right? If you're going to use allograft bone, or these spacers that are prefabricated, right? There's tons of stuff that's out there that'll increase your cost. I'm not quite sure it changes your outcome, right? Doing it at every level versus skip level. So these are just things to consider. I think Jack's point of undercutting is really important. And I think Jens brought up the preservation and the reparative technique. I think some of the people on the chat line brought up are super important in terms of getting optimal outcomes, right? And getting people moving. Maybe you can move on, Kaylin, to the next case and we can wrap it up. A different patient, right? A completely different patient.
Correct. This is our 62-year-old female with neck pain, myeloradiculopathy, BMI of 45, retired laundromat employee. And here are her post-op radiographs here. Showing us.
This is a different patient, right? This is a patient that had a significant amount of neck pain, I think you had said, Kaylin. Neck and arm pain, radiculopathy, that was a predominant driving factor, very spondylotic, multilevel stenosis, right? That may not be the best candidate due to her presiding neck discomfort and pain, and maybe a better candidate from a fusion perspective.
With that, we'll move on to any open discussion comments before we close.
So we want to sort of end it by just saying thank you and for allowing us to participate today. On behalf of the neurosurgery and orthopedic department at Maryland, we really enjoy these discussions that we can have in participating in the journal club. Hopefully, everything's crystal clear, right? The literature clearly guides us toward the right answer. So lots of work, as Jens sort of pointed out, needs to be done from a society level. But hopefully some of the literature that we discussed today can help guide treatment to a certain extent, right? In selecting the right person and optimizing our patients. So with that said, once again, thank you guys very much. We really enjoyed participating today.
Thank you, Steve. You did a great job as per usual. But wonderful hour. Thanks.
Thank you, guys.
Echo that. You guys did great. Super topic. Really well presented. Y'all take care. Stay safe.
Bye-bye.
Thank you.